Welcome everybody to our September webinar. We're very excited to have Dr. Postma here to discuss very current, recently funded NINR research regarding the wildfires, which is incredibly timely. And because ANHE is a national organization, we really are very lucky to have this perspective. I'm going to turn the mic over to Dr. Postma because we're very eager to hear about her work. Thank you.
Well, thank you so much. I'm Julie Postma. I'm the Associate Dean for Research at Washington State University College of Nursing, and very pleased to be with you all today. I'm going to start my screen share, so let me know if you can see that.
It looks great.
Yeah, okay, excellent. So today I was invited to talk about, as she said, NINR funded study called Promoting Risk Reduction Among Young Adults with Asthma During Wildfire Smoke Events. And Washington State University is a land-grant campus, or land-grant university rather, with campuses throughout the state as indicated by the red dots on this map. I'm actually located in Seattle, denoted by our beautiful evergreen there. And I just have to give a shout out for our PhD program. If any nurses are interested in pursuing their PhD, we are here for you. It's primarily online, some in-person classes as well. So if you're inspired by this talk and by environmental health, please reach out to me, and my contact information is on that first slide. So the research team that we built for this study includes colleagues from nursing, medicine, engineering, and even the Environmental Protection Agency with Anna Rapol. Patricia Butterfield, some of you might know because she is certainly a nursing leader in environmental health, and she is my mentor. So today I want to share some information, some background on climate change and wildfires, our very current summer experience with wildfire smoke, information about an app called SmokeSense that the Environmental Protection Agency developed, our current study which modified the SmokeSense app and tests both apps among young adults with asthma. And then finally, I'll share some resources, and to keep this engaging, I will show many pictures and visuals from across our state, including this one, which compares the view from the Space Needle the week of September 9th through 14th, and you can see how drastically that view has changed. So first, a little background and significance on climate change and wildfires. The Union of Concerned Scientists help us visualize the connection between climate change and wildfires in this image. They note that while fire has historically been a natural part of many wild landscapes, global warming has changed some of the underlying variables that make wildfires more or less likely to occur every year. Temperatures are rising. Warmer temperatures increase the likelihood that fires will burn more intensely. They also cause snow to melt sooner. And here in Washington State, our mountains really act as reservoirs. So when snow melts early, and winter snowpack melts up to 4 weeks earlier than they have in previous decades, our soils, our forests, our plants become very dry, which act as kindling. Increased droughts, unusual rain patterns, and insect outbreaks that lead to large stands of dead trees are also connected with climate change, and they all make wildfires more likely. Over the last 30 years, the number of acres burned per year has increased. Human-caused climate change caused over half of the documented increases in fuel aridity since the 1970s and doubled the cumulative forest fire area since 1984. I include a resource at the end of this talk, TED Talk by Paul Hesburgh, and he talks about megafires in much more detail and land management that I think this audience would in particular appreciate. Okay, back to home here. Annually, wildfires are starting earlier and lasting longer, extending the smoke season. They're expected to increase in prevalence and severity in years to come. Wildfire smoke travels long distances and affects many more people than the wildfire, those endangered by the fire itself, which is, of course, not too underscore the importance and tragedy of those events. On the right, you can see a satellite image of smoke in our western region from just a couple weeks ago, September 12th. You can see that Washington, Oregon, and California are almost entirely covered in wildfire smoke. On the left is the air quality index from that day, showing the decrease in air quality, and in this case, the increase in the air quality index, which shows that the air quality reached hazardous conditions, and unfortunately, it stayed there. After the 2017 fire season, I shifted my program of research from looking at indoor air quality and its impacts on asthma to really starting to look at outdoor air quality and the huge impacts from wildfires that we're facing. More Washington communities have been exposed to more hazardous levels of particulate pollution than we've ever seen since we began monitoring for it in the early 2000s. Notably, if you look at this graph, you can see that last year, 2019, we had few fires. This definitely set us up for huge events this year because of all the fuel that was available to burn this year in the wildfires. The graph also illustrates that this year, which is not over, as we know, almost 80% of our state population was exposed to unhealthy air for periods of 5 to 9 days, and a proportion was exposed for 10 to 14 days. Notably, this air quality is unhealthy for all and not just sensitive populations. So what is wildfire smoke, and how does breathing wildfire smoke impact us? Smoke contains several compounds, and its composition depends on what is burning, the fire temperature, and the wind. Wood smoke contains carcinogens, but of principal concern is fine particulate matter, or PM 2.5, a mixture of small particles that can be inhaled deeply into our alveoli. Sources of particulate matter might be direct from construction sites, unpaved roads, fields, and agricultural burning, smokestacks, or fires, and also indirectly from chemical reactions with sulfur dioxide, nitrogen oxides, and pollutants emitted from power plants, industries, and automobiles. And I should mention too that in the Western region, many people burn wood for heat, and so that's a huge cause of wood smoke in our winter seasons. This image compares the size of fine particulate particles. You can see on the upper right the PM 2.5 there, and that is in comparison to human hair. There are several theorized ways in which particulate matter results in systemic damage. One is that inhaled particulate matter leads to both a localized inflammation in lung tissue and a systemic inflammatory response. Another is that the particles penetrate lung alveolar endothelium and enter directly into the circulation, causing inflammation. So most theories do focus on particulate matter that is inhaled, but leading to systemic inflammatory triggers and an oxidative response. Wildfires now produce 1/3 of the fine particulate matter in the US, and we do not see this going away. Among people with asthma, exposure to PM 2.5 from wildfire smoke is associated with a myriad of effects. And I like this because it shows the pyramid of effects from air pollution, where the magnitude of, comparing kind of the magnitude of impacts with the severity of effects. So we know that low levels of PM 2.5 are associated with increased asthma symptoms, increased daily doses of reliever medications, and initiating oral steroids. Moderate levels are associated with asthma-related emergency department visits. And increasingly, although not shown on this slide, research are documenting a positive association between exposure to PM 2.5 and psychological distress, which also influences asthma exacerbations. In the United States, air quality alerts reflect the air quality index, which relate to federal health standards of 5 air pollutants, including PM 2.5. The air quality index, as you can see on the left, ranges from 0 to 500 and is divided into 6 color-coded categories with values related to a level of health concern. Advice in the third column corresponds to whatever subpopulation you are in: sensitive people, everyone else, and even unusually sensitive people. When checked daily, the air quality index can help us make decisions about when to open our windows to ventilate our homes, when to go for a run or a bike ride, wearing a mask when you're outdoors, or canceling school or even a county fair, which we had a couple summers ago. This is another view of how one could use the air quality index to assess air quality regionally. And you can also, they forecast the air quality 24 to 48 hours worth. There are research gaps. Existing research in nursing, public health, and risk communication has not reduced the uncertainty in how to best respond to sustained wildfire smoke events. Air quality alerts lack evidence of effectiveness. Actual adherence to the advice to, for example, reduce or reschedule outdoor activities ranges considerably, 10 to 57% in one systematic review with a median of 31%. And then other activities, such as taking meds or avoiding busy roads, has an even broader range with the studies that were reviewed, between 18 and 98%, with a median of 46%. Research relies on self-report, largely, of behavior change, or sometimes even intended behavior change. It tends to be observational and descriptive. And we need to examine modern communication channels, specific communication channels to reach at-risk groups, and the oversimplicity of the stay indoors message. Again, when we have a 1 to 2 week period of hazardous air quality, staying indoors, as I know personally, can make one stressed, anxious, and overall imbalanced. So the Environmental Protection Agency's SmokeSense smartphone app is an innovative risk reduction intervention based on the health belief model and theory of planned behavior. And the app was launched in 2017. The health belief model suggests that understanding perceptions, motivations, and barriers to behavioral change among impacted individuals can help us understand the likelihood of engaging in health-promoting behavior. So kind of going left to right, I asked the question, do people perceive that breathing wildfire smoke will result in asthma exacerbations? People with asthma. And do people with asthma, especially young adults, perceive themselves to be a sensitive group? As I just showed you with the air quality index, it is divided by sensitive populations and non-sensitive populations, but people don't always perceive themselves to be a sensitive population. Moving to the middle column, do people know what to do, how to do it, and that they can do something to reduce their exposure to wildfire smoke? So drawing on the health belief model, the SmokeSense app encourages preventive health behaviors, and the preliminary data has been very informative. On the left is a diagram reflecting what we have learned about the relationship between health history, that's the H, symptoms, S, mitigating behaviors, such as taking medication or seeking a healthcare provider, and exposure reduction behaviors during a wildfire smoke incident. For example, staying indoors, recirculating indoor air, using a HEPA filter, things like that. And what we know from preliminary data is that the app users are responding to symptoms versus preventing exposures in response to their health profile. App users, including those with asthma, do not perceive their susceptibility to smoke or the seriousness of breathing the smoke, and therefore do not reduce their exposures before they experience symptoms. And in contrast, the desired relationship over on the right between health histories, symptoms, mitigating behaviors, and exposure reduction behaviors, this shows that we want people, especially who have a health history of asthma, to engage in the exposure reduction behaviors so that they do not have symptoms or need to go to the hospital or the ER or a provider. And incidentally, this was very much my motivation as a cardiothoracic ICU nurse for going back to graduate school to study occupational and environmental health. It was all about prevention. So more specifically, the app invites users to record their smoke observations and their personal health symptoms and explore what other users are reporting. So users can look up current and forecasted daily air quality, map fires, view satellite images of smoke plumes, and learn strategies to minimize exposure to wildfire smoke and breathe cleaner air. You can earn badges for each of these activities, and you can engage with other users by viewing cumulative statistics of symptoms and smoke observations. So most importantly, and what really excited me about this existing app was that SmokeSense connects air quality exposure data with users' symptoms, thus framing risk reduction messages as personally relevant. These are just a couple more slides about what the SmokeSense app does. You report your daily symptoms and smoke observations. Again, it's a more personalized approach. This is one way that I've been using the SmokeSense app is mapping the fire and smoke near me. It helps me understand conditions on our various campuses, for example. Spokane campus was closed last week because of hazardous air quality, and that helps me understand why. It also informed my family's choice to cancel a vacation in a particularly smoky region of the state. You can see here that the air quality index in Spokane was 496 for PM 2.5, and on our Vancouver, Washington campus, it was 562. Notably, the air quality standard for PM 2.5 as a 24-hour mean is 35 micrograms per cubic meter. An Air Quality 101 module leads to trivia games which test knowledge of air quality facts and provide correct answers for each lesson. Of course, promoting people to engage in learning tips and strategies to protect their health. And as a citizen science project, users can also check what other people are reporting. So I was really excited about this app, and I cold called Dr. Anna Rappold from the EPA to express my interest in testing it in a particular population and using objective measures. And from there, our team developed an R21 application to NINR. Then COVID hit. Then we adapted that a little bit, and the study was funded earlier this year in April. So we got going in anticipation of this year's fire season. Thank goodness. So in particular, I was interested in young adults with asthma as a high-risk group and as a group that uses different communication channels than we've often used for air quality alerts. Young adults are less likely to adhere to air quality alerts than older adults, yet young adulthood is a time when habits are formed in chronic illness management, and of course we want to keep young adults healthy. We want them to be exercising, etc. Portable digital media and social networking are pivotal in young adults' lives, with 96% owning a smartphone, 88% reporting the use of social media, and at least 80% checking social media daily. Leveraging the peer influence of this communication revolution is critical to give young adults with asthma actionable and accurate information that they can use to prevent exposure and minimize their risk. So getting to my study, the purpose is to assess the feasibility of risk reduction interventions among young adults with asthma and pilot test the interventions compared to a control group. My first aim was to establish the feasibility, acceptability, barriers, and facilitators of adopting the technology of the interventions and use of portable spirometry in young adults with asthma. In other words, do they like it? Do they use it? Are they bored? Is it clunky? And then second, to explore the preliminary impact of the interventions on health outcomes. This is a 3-arm randomized controlled trial with 20 participants in a control group that are not using an app, 20 participants using the EPA SmokeSense app, and then 20 participants in a SmokeSense Plus intervention group. And Plus stands for peer-linked user sharing. You can see on the right, the app that we created incorporates the SmokeSense app, but also a couple other things, which I'll talk about more in depth in a minute. Our sample of 60 will be adults 18 to 26 with asthma. We're about 2/3 of the way there, thanks to your organization and others. Our study period is 8 weeks. We are taking measures at baseline, 2, 4, and 8 weeks. I should say, let's see, we're recruiting primarily in the West. Primarily where, in wildfire prone areas, there doesn't have to be a fire. Much of this is prevention focused. But we'd like people to be in an area that a wildfire could occur. And let's see what else. We're collecting data via the REDCap system, and this has all been approved by WSU's Institutional Review Board. The design enables an examination of processes that are key to the success of a future clinical trial and also allow us to estimate the effect size of smoke sense interventions on our primary outcomes of interest. Those include lung function, asthma control, and asthma quality of life. And combined, these outcomes measure multiple domains of asthma, including lung function, symptoms, activity limitations, urgent care visits. And as you can see again from that pyramid of effects, we kind of pulled some from each of the levels. In particular, lung function is theorized to show up early, so we're hoping that we will see that. Use of a handheld spirometer is one innovation I kind of wanted to pull out because we're very much testing that, seeing if that even works in the field. Lung function indicates a future risk of adverse outcomes. It's regularly monitored in asthma via peak flow meters, and provides an early warning sign of airflow obstruction. Traditionally, spirometry is done in a clinical environment, often with a specialist, as you can see by the picture on the left. You measure airway obstruction by blowing into a machine, measuring forced expiratory volume, forced vital capacity, and their ratio. But in recent years, portable spirometers have been validated against conventional spirometry. So we are trying something new. People are doing these maneuvers at home. We train them. We've learned a lot about what that's like in our onboarding visit. Which is largely done by Zoom now because of the COVID pandemic. And we'll see if participants can perform a quality maneuver using this device at home. We're also interested in a number of secondary outcomes. That includes exposure reduction behaviors listed there on the right, mitigating behaviors such as using rescue medications, controller medications, oral steroids, and unscheduled healthcare appointments, and then anxiety and also stress, which is not on my slide. Some of these behaviors, the exposure reduction behaviors, will be impacted by COVID, especially, for example, wearing a mask, and that would be an N95 mask. That may be less available. Nonetheless, we will see. And another innovation I wanted to point out with this study is that typically those behaviors are reported, self-report. But we built in GPS with our app. Excuse me just a second. So GPS data includes coordinates with timestamps and will be used to estimate intervals of time in minutes that participants spend daily, staying indoors, being outdoors, and spending time in a vehicle. So again, we have two intervention groups. One's using the SmokeSense app, and the second is called SmokeSense Plus, and they're using what we call the U-Track app. We created this app in collaboration with the EPA. Dr. Anna Rappold is part of our team. And we developed the U-Track app to increase perceived susceptibility and perceived severity among users with asthma to the health effects from wildfire smoke. Again, very much based on the preliminary data and the health belief model. The SmokeSense Plus intervention builds on the SmokeSense app with evidence-based and value-added activities to decrease barriers and increase self-efficacy, such as notifying participants to review their asthma action plan, monitoring lung function daily via portable spirometry, and subscribing to a message board to share strategies to minimize exposure. So it's really designed to leverage social networking and peer-to-peer influence. And we'll just take a look at a couple features here. The middle image, again, is kind of the home page. On the left, you see that the SmokeSense is embedded in the U-Track app. And then on the right is what, if you were to click on peer-linked user sharing, you would see these advisories, the message board, and Map It. So the Map It is a combination of the advisories and the spirometry. So twice a day, this intervention group is using their handheld spirometer. So it builds on that idea of noting your symptoms with the air quality. We automatically request, if the air quality index is greater than 50, that they do another maneuver, another blow in their spirometry, and that those requested blows are mapped to the location for other users to see. So it's not exactly their location because of privacy issues, but it's within a couple block radius. And the red lung icon would indicate that they're at 50% or less of baseline. The yellow indicates a 50 to 79% of baseline of their peak expiratory flow, and the green is greater than 80% of baseline. So you can see what the visual impact might be. We will find out of these little lung icons on the map, and those correspond to these advisories. Another feature is a built-in message board. So we post a weekly tip that rotates every week for the 8-week period. Participants have a chance to respond to the tip, and they can interact with each other. So we see here some interaction between talk of an asthma action plan. Beach, which is a pseudonym, is from Arizona. Again, there's privacy kind of built in here. And somebody else asks, oh, what time of year was considered wildfire season in Arizona? Finally, analysis. So this is an ongoing study. We are, again, currently recruiting participants. I'm not spending much time here on analysis, but we are starting to dig in a little bit to AIM 1. So we will use descriptive statistics to examine recruitment and retention rates and characteristics of participants who drop out early compared to those who complete the study. 8 weeks was kind of a shot in the dark. We know with SmokeSense, most people use it for a 2-week period. We wanted to make sure we built in some time to think about and get ready for smoke season. So that prevention sort of prompted some more time, but we'll see. We'll see if 8 weeks, if people stick with us or not. Also looking at acceptability. So we can look at how engaged people are in the app, what features they're using, the order in which they use the features. Do they check the air quality index daily and then do their spirometer, for example, or the other way around? And they can earn badges through SmokeSense. So we'll see which activities they're earning badges through doing. We're also doing the system usability scale and the research attitude scale, which will give us a little more information. And I'm in the middle of writing another IRB application, institutional review board application for undergraduate honors nursing students who will be conducting interviews with participants in either of the intervention groups to learn a little bit more. And she insists that she has a unique perspective on this, and no doubt she does, because she's been in on our research meetings and notes that her concerns about the app are very different than what we're all talking about in our interdisciplinary research team. So I'm very excited about her participation. Generalized linear mixed models will be used to explore the preliminary impact of the SmokeSense interventions, and that is my colleague Tamara Odom-Marion will be working on that piece. She's a biostatistician. So I just wanted to show one other kind of local find here, because it really brings up the tension between the COVID precautions and wildfire smoke precautions. So Fremont Brewing has this big, beautiful outdoor patio in Seattle. People gather there. That has been good for COVID, but then we had the wildfire smoke. So I was pleased that they had on the sign indoor only due to air quality, but at the same time, again, there's a tension there between public health advice, and that's confusing for people. So I want to also note that we're still recruiting, and I think, yes, these are my resources. So the ones I pulled out were the EPA's SmokeSense Citizen Science Project. So you can sign up for this app, it's free. You can get a better sense of all the features. They come alive when you're actually, hands-on. This is a publication about the Smoke Sense initiative. There's an excellent Environmental Protection Agency continuing education module called Particle Pollution and Your Patient's Health. Again, that's free. You can get continuing education and you can learn much more about particle pollution. And then finally, this TED Talk by forest ecologist Paul Hesford, who is in Washington State. And we co-presented at a forum our health department, Spokane Regional Health Department, put on. So he very much spoke about the land management and kind of the history and the impact of climate change, and I talked about the health effects. So I invite you to check that out as well. And with that, I will stop my screen share. Just give me a minute, and we can open it up for questions. Stop. Okay. Did that work?
That was fabulous. I loved it. It was excellent. Your resources are great too. I'm kind of excited to go explore those once we get rolling with our chat. I'm going to go ahead and stop the recording now so we can just have an informal discussion, but great. Wonderful. Thank you.